Hey everyone, it's Josh at Prescription Fitness Physical Therapy and Sports Care, bringing you another segment tonight. I just wanted to talk a little bit about a common question that we get, which is how do you really know what's going on? So if we don't have an MRI, if we don't have an X-ray, if we don't have diagnostic imaging, how do we as your physical therapist know what to do and what to treat? Well, it really comes from our clinical examination. And I think that understanding what a clinical examination looks like, and maybe you can compare it against, what did your clinical examination look like when you went to physical therapy at your practice, so you get a sense of how detailed it is. Because I think nowadays, if you go to see your doctor, very often you're limited in time. I think in some of the orthopedic offices, you might have 3 minutes. I know at one point there was a study that looked at, how long does the average primary care physician spend with their patients, and if it's a female physician it was somewhere along 9 minutes, and if it was a male physician it was like 7 minutes. So that's not a lot of time to glean information that is useful and relevant and important in coming up with a clinical diagnosis and how we treat. So this is kind of how we treat in the physical therapy world. So I'm going to break it down for you just quickly, looking at things. So the first thing we do, and this is following more of what's called a Syriax evaluation. Not everyone does this, but it's sort of, it should look something similar to this. So the first thing we're going to do is we're going to look at posture. And posture in and of itself, there's not a lot of literature that really shows that bad posture causes these problems. We all like to think that it does, but I don't think there's a lot of literature that shows there's a direct cause and effect to that. So we're going to look at the posture. We're going to say, okay, how does a person look comparatively? Does they have a big lateral shift of their head? Is one shoulder elevated? Is the position of their shoulder blades equal onto their trunk? And if it's not, is that important? Maybe it is, maybe it isn't. We're more going to look at it then dynamically. Does that change? So we look at the posture. After the posture evaluation, then we're going to go through, typically we're going to go through active range of motion. Active range of motion is really looking at, let's say in the shoulder, we're looking at the willingness to move. Can the arm move through certain planes? What is the willingness to move? So what's stopping the patient from doing this? Next thing we're going to look at is we're going to look at passive range of motion. Passive range of motion is where we as the therapist will take the limb of the body part and we'll move it through a range of motion. And we're looking for a number of things. What is the end feel? And end feel is just what is stopping the movement. So if I pull your finger all the way back, what we feel is a firm or a tissue end feel. Sometimes we might feel an empty end feel. An empty end feel to us means that there's maybe inflammation, or maybe this is a neurological, or maybe it's even a psychological type of an issue. If we don't feel anything, but you, the patient, is saying, ouch, that hurts. So passive range of motion, we're going to glean that. We're also going to be looking at pain to resistance patterns. So when we move it, we can feel intrinsic stiffness or something that's stopping the movement, and that may be when we move you. If we don't feel anything and you go pain, that's what we call an empty end feel, and that again, that's a real painful situation that may indicate that something's acute. Or if I take a tissue, I go into a tissue end feel, and then I take it even further to the very end of the movement physiologically towards the end, and then you go out. That might be more of a chronic situation where we know when we get into treatment, we're going to be able to push that a little bit further. So that's our passive range of motion. Looks at some other things, but that's sort of a quick gist of that one. Neurological screening, super duper important. So if your physical therapists aren't doing what we call upper quarter screens or lower quarter screens, I think we're probably missing something there. And so this is where we're going to screen through the system, and we're going to screen, so if we're looking at a shoulder, we're also going to screen through the hand, wrist, elbow, the nervous system. We're going to look at reflexes. We're going to look at sensation. We're going to look at strength, which correlates with what are called myotomes, which is a more complex topic. Again, it gives us some information about the competency of the nervous system. So upper and lower quarter screens, absolutely important. Functional testing. Functional testing is where we're going to look at common movements and see how that correlates. So gait, just looking at seeing how someone walks. When was the last time you went to the doctor's office and someone actually had you walk and you went there with a foot problem? Well, you better look at it. What you're finding out is a lot of information, again, about the willingness to move, maybe compensatory patterns. Could be a whole host of things just by functional testing. Are there deviations? Are people compensating by turning a foot out or shifting their body weight over or showing an increase in trunk lean when they're squatting? functional testing, super important. And all this is in one clinical examination. We're not even done. So then we're going to look at resisted testing, resist isometrics. We're going to look at it, is something painful? Is it weak? What's that telling us about the contractile elements of the tissue? It tells us a ton of information, and we're looking at somewhat of a submaximal level. And then on top of that, we're going to finish it off with muscle testing. And muscle testing, some people will use a grading scale 1 through 5 or 0 through 5. I don't know, it's kind of subjective after we get past 3, which means I can move the body part against gravity through a full range motion. My personal opinion is it's too subjective. It depends on, am I having a bad day? Am I feeling weak? Did I go out and have a drink last night and I can't, I'm not pushing as hard, who knows? So we're going to use a muscle tester, a handheld dynamometer, to look at things in pounds of force. And again, it's going to give us information. And we're taking each piece, each subset of the clinical examination, we're throwing it together to finally come up with a clinical diagnosis. Last part are usually special tests. And special tests, right now they're controversial. Whether they really tell us for shoulders, there's 17,000 tests to look at labral injuries, whether it's a slap lesion or a Bankart lesion or whatever it might be, and how valid and reliable are we really able to use these tests to narrow it down. But again, I think that if we look at it just as a whole, it's telling us a lot about the tissue and the volatility or stability of the tissues and what we can do. So if we take all those things, it takes a long time to look at that effectively. So our clinical exams here, prescription fitness physical therapy, are an hour long because we look at all of those things, and we look at all those things on a daily basis. So that's just the detail of what a physical therapy clinical examination should and probably looks like at the facilities where you go. Compare and contrast it against maybe some of the physicals or the evaluations that you get with other practitioners. I think, again, physical therapists do a great job at this. So next time you go see your physical therapist, this is what you should expect. This is why it takes so long. So this is Josh at Prescription Fitness Physical Therapy, and we'd love to hear from you guys. So if you have further questions, send us emails through our Facebook site. PrescriptionFitnessPT.com is our website, and you can link directly to our Facebook site.